Thanks so much for having me tonight. So as a journalist, we talk to people and hear their stories, and so I just want to emphasize that I can give sort of an overview, and I hope what I can offer is some perspectives from people that I've met ever since I've started reporting on the opioid crisis, probably since about 2012. But certainly you'll hear after me people who know far more. You'll hear from physicians who know this crisis. You'll hear from a frontline worker at one of the overdose prevention sites. But I'm here to give you a somewhat oversimplified but sort of concise idea of how we got to where we are now. So as Richard said, yes, we're hearing about fentanyl, and we're hearing about it in the context of deaths and overdoses. We know the stats. We know 4,000 people, the latest numbers. I think they were flashing on the screen earlier. We know 4,000 people died last year of overdoses, most of those attributed to fentanyl. That number is probably much lower than what's been actually counted by the government, because of course we'll have deaths that can't be accounted for. They don't know the cause. We know that number is 1,000 more almost than the year before. So we know that this crisis is escalating at a rapid rate. And we also know from police seizures, we know from different data that fentanyl contamination in many drugs is increasing as well. We did a story last year that showed that something like there was a 2,000% increase in the number of drugs seized by various police authorities across the country that were found to be contained with fentanyl. A lot of that's heroin, a lot of that's cocaine, but the bottom line is people using drugs on the streets really don't know what they're taking. So let's start with how we got here in the first place. Now, am I using the right thing? There we go. OxyContin. So before I can talk about fentanyl, I need to go back and talk about what happened with OxyContin. And I should give full disclosure in the interest of transparency as a journalist. I've been interviewing Dr. Uhrlink for several years now. So if you have any questions about what I'm saying, you can talk to my source. He'll be up later. Opioids are not new, right? I mean, we've had opioids. Opioids have been part of treatment, part of pain management, part of treating acute pain in hospitals for years, whether it's morphine or codeine or oxy. OxyContin came on the scene, and it was meant to treat acute pain. So post-surgical pain, cancer pain, in many cases when people were terminal. And so what happened was Purdue Pharma, the manufacturers of OxyContin, had this drug. And then and physicians were prescribing it, and it was being used in hospital settings and in controlled prescription settings. And then at some point in the 90s, Purdue Pharma started to market it as something that could be used for chronic pain management. And so we have a whole generation of doctors and primary care providers who were going to medical school and who were trained, first of all, in med school, that this was an appropriate treatment for chronic pain. And we had a whole bunch of doctors who were receiving material from Purdue Pharma and who were being told that this was this sort of standard of care for dealing with people with chronic back pain, et cetera. Well, if you prescribe something for chronic pain, you're obviously prescribing a lot of it on an ongoing basis. So doctors were also told by Purdue Pharma, and we know this now, that it was not addictive, that the risk of addiction was very low. So physicians thought they were doing the right thing for the most part, thought they were caring for their patients, thought they were relieving them of some really horrible pain ailments. And then it became clear later, as patients started to become addicted, that this was a problem, that addiction was a very real risk. And so what we end up with at that point is with patients who are dealing with their chronic pain, they're being treated for their chronic pain, and they're now addicted to OxyContin. The other part of that is that not only do we have the patients, but because there was such a volume of OxyContin prescribed, that meant that it was out there and could be diverted into the streets and into places where it shouldn't be. So kids experimenting with drugs, so Oxy was in their parents' medicine cabinets. It became a street drug. And there was a sheer volume of it and a demand for it. Those people then in turn would become addicted, so more so than they might have expected if they were taking, if they were smoking pot or if they had been even taking cocaine. This was so incredibly addictive that now you have this whole other group of people who are either physically dependent or addicted to oxy. And when I was a reporter in Thunder Bay around 2012, it was starting to become clear to me that this was an issue. And at that time, oxy was going on the street. One single tablet of oxy was going for $80 on the streets of Thunder Bay. Now the street value of a drug probably depends on where you were. That might have been less in bigger urban centers where you could get it more readily. But that's what it was going for in Thunder Bay. So the other thing that happened was the healthcare community started to realize that there was a problem and started to realize that this needed to stop, that people were addicted. But in many cases, this wasn't handled with appropriate withdrawal management, because the other thing about OxyContin and opioids, and my colleagues will be able to talk more about this in more specifics, but the withdrawal symptoms are unimaginable. I've talked to people who have been addicted. I've talked to physicians who specialize in this. And it's been described to me as feeling like your body is turned inside out. It's the most unimaginable pain that you can think of. So now we have people who are addicted, even trying to get off, may have been prescribed oxy for legitimate pain, and now we have people who are not only dealing with their pain, but kind of stuck because they can't deal with the withdrawal symptoms. Because they're human beings who could, really. They're horrible. So at the same time as that's happening, we're dealing with other issues, and I can speak to Thunder Bay. So in Thunder Bay, we were dealing with a doctor shortage at that time. There were very few, I was doing stories about the primary care shortage. They were doing things to try and mitigate that, bringing in nurse practitioner clinics, that kind of thing. But there were so many people without doctors that when doctors and the medical community started to realize that they need to stop prescribing oxy, or thought they need to stop prescribing oxy, these people ended up cut off, because no walk-in clinic, once this sort of became a thing, no walk-in clinic would prescribe it. So people were sort of cut off cold, and they didn't have the appropriate primary care provider to provide them with withdrawal management. They didn't have any of those things that are required to properly manage an addiction. So people got desperate. The other thing that happened at the same time that we saw while I was there was that Purdue Pharma, the manufacturers of oxy, decided that for their part, they were going to try and make it quote, tamper resistant. So what they were going to do was they said, okay, we see that people are abusing OxyContin. We're going to change the formulation. We're going to change it to something called Oxy Neo, which was supposed to be, so essentially it made the pills harder, so you couldn't crush them, you couldn't snort them, they thought. Because that's how people got high, was by taking a time-release drug in a rapid fashion. And also you couldn't melt it down and inject it, because that's what people were doing. And when that was happening, I had a woman named Sherry who had suffered a back injury. And she became a really important source for me. And I would call her frequently and ask her I asked her about what she thought about this new formulation happening. And I said, what is going to happen to your friends she knew a lot of people who were addicted to oxy. And she said, you know what? She said, people who are addicted will find another way. Said people will find something to feed that need to prevent those withdrawal symptoms, whatever that's going to be. So, and they did. And I also talked to experts back then who were also worried that people would find another path, anything really to prevent those debilitating withdrawal symptoms. And what they thought was going to happen was that people would turn to heroin. And in fact, one of the street names for oxy is hillbilly heroin, so it made sense. And people did turn to heroin. But the other thing that happened was fentanyl. And Richard mentioned fentanyl. Fentanyl was a very acceptable, perfectly appropriate prescription for pain management, again, acute pain management in hospitals, in medical settings, generally would come in a patch, so it could be time released and dosed appropriately, because fentanyl is incredibly potent, as we've heard. So when given in the appropriate doses, it was appropriate for pain management. But because it was so potent, the dealers, drug dealers, discovered that this was a way that they could stretch, essentially, their drug supply. So if they were selling heroin, so we have more people turning to heroin, for instance, because they need another opioid, because they're going through these horrible withdrawal symptoms, plus they still have the pain if they're prescription patients, plus they have the pain that they're dealing with. So they're looking for an alternative. Drug dealers are trying to stretch that heroin supply, so they start adding fentanyl. And it turns out fentanyl is actually very cheap. It's cheap to import. You'll hear a lot of reports about imports coming from China, for instance. People can actually make it. So it started to contaminate, essentially, contaminate the street drug supply. So heroin, cocaine, often mixed in with there. So fentanyl became a huge issue as well. So as Richard brought up, it was kind of both. Yes, it was a prescription drug and is a prescription drug, but it also became a street drug as well. And people would also turn to, not only were dealers mixing that into things like heroin and cocaine, but people were also turning to fentanyl as an alternate opioid to stave off those withdrawal symptoms. So I want to talk a bit about, that's sort of a brief and largely oversimplified history of how we got here. But I want to talk about what happened to the actual people involved. So, as we all know, and I hope that this is improving, and I hope this is starting to improve over the years, but there is a huge amount of stigma associated with addiction. And nobody, if there's one thing I can convey tonight, is the one thing that I've learned is that nobody is immune from addiction. Nobody in this room. It can happen to anybody. And opioid addiction can happen to anybody. So I want to talk about, and the reason I don't have a picture here, I will have pictures in the slides coming up, but I want to talk about this man that I interviewed, because I was doing a story about the doctor shortage in Thunder Bay, and I wanted to see how the opioid crisis, essentially, how those two factors mixed together. So I found this gentleman, and he was just a salt-of-the-earth guy, late 50s, had worked hard his whole life. He'd had a workplace injury years before. So he'd been prescribed, and he had been prescribed fentanyl patches. And he lost his doctor. So then what happened was he went to a walk-in clinic, and given that the opioid crisis was underway, the walk-in clinic said, no way, we're not prescribing this to you. You're just gonna have to stop. Didn't have any appropriate withdrawal services. He lived in a rural community outside of Thunder Bay. So he started rationing I went to see him at his farmhouse, and he was telling me about how he started rationing his patches. He started cutting them in half, he started cutting them in quarters, anything he could do to sort of stave off, A, the back pain from his injury, and B, these horrible withdrawal symptoms he was starting to have. And then eventually, he ran out, and he found himself standing in downtown Thunder Bay in line at a methadone clinic. And methadone, for anyone who doesn't know, is an alternate opioid used to treat opioid addiction. The idea being that you prevent the withdrawal symptoms without getting the high from it. And he just thought, and again, a lot of stigma involved in being in line at a downtown methadone clinic. And he just said, you know, like I never in my whole life thought I'd be here. So I thought it was a really important story to tell. Now, a few days later, before we had a chance to air the interview, he called me in the newsroom, and he had actually managed to find a doctor in a clinic. And I don't know what happened in his conversation with that clinic. I don't know, I wasn't there. I can't say it had anything to do with the clinic for sure, but all I know is this. He got to the clinic, he had some kind of conversation with them on intake, called me back, and he said, I don't want this story out there. Please don't print anything or broadcast anything that I said. So all that to say was that just showed me how much stigma there is attached to having an addiction and being public with an addiction, even if you're trying desperately to stop, even if you're trying to get treatment. So that spoke a lot to me. The other thing when I worked in Thunder Bay was, so you can imagine all of these people who are addicted, sheer numbers of people who are addicted to opioids, say in a big city. Imagine if that happens in a remote community where, say, only 1,000 people or so live there, and you're dealing with a First Nation community that is already struggling with drug use of some kind because of all kinds of factors, which are too numerous to get into tonight, but intergenerational trauma from residential schools, abuse, all kinds of poverty influences. So you had people you had communities that were absolutely decimated because they were already dealing with a drug problem. When Oxy came on the scene and Oxy reached these communities, some of these communities I talked to, a lot of First Nations declared a state of emergency in Northern Ontario. I had people tell me that about half of all the people who lived in their community were addicted to Oxy or to another opioid, and it was devastating. So First Nations communities a lot of them tried to take action and tried to help themselves. So I went, a year ago, February, I went to a community called Iqaluit First Nation. It's also called Fort Hope. And it is a flying community. It's about 400 kilometers north of Thunder Bay. It has about 1,300 people living in it. So these are some pictures that my colleague Edu took while we were there. It was freezing. It's February. It's way north, Northern Ontario. But each day, they would come to the Suboxone clinic, and this is what they had done to try and manage this. They had started a Suboxone clinic. Suboxone, like methadone, is an alternative opioid. It's also mixed with its part opioid. Suboxone's part opioid, part naloxone, which is an antidote to opioids. So the idea being to try and help people to manage their withdrawal symptoms that way. And the other thing about Suboxone that works in First Nations communities is that its doctor doesn't have to have a specific, doesn't have to get a specific license to have people deliver it. So it's easier to take it far away than methadone. And this is a gentleman named Sid, and he's from that community, and he was telling me about what had happened and why they wanted to bring the Suboxone clinic in so badly. And he was telling me about how he was one of the counselors who lived in that community, and he was telling me about how he would go during the Oxy crisis to go on home visits, and the houses would be completely empty. No furniture, no pots and pans, no food, because people had sold everything they owned because they were so afraid of those withdrawal symptoms, and they were so desperate to buy Oxy or whatever opioid. And if it's going for $80 a pill in Thunder Bay, you can imagine what it's going for in a remote community like that. So they were fighting back with this clinic. This is Wanda Sugarhead, and she is one of the most inspirational people I have to say I've met in my career. She herself had dealt with child abuse. She herself survived a suicide attempt. She managed to, she was addicted as well to opioids. She took herself out of the community. She did it for her kids. She's like, and one day she just said, I just need to help myself. She did manage to get treatment. She had to go to the States to do it. But she came back, she went to Confederation College in Thunder Bay and got her social services diploma, and now she heads up the prescription drug abuse program in Iqaluit First Nation. And this is what it looks like. So every day they come to this clinic, they brave the cold. About 100 people a day in a community of 1,300 come and take their doses. This is Luciette Lucan on the left. She herself, and this is what communities are dealing with because they are so under-resourced. She herself struggled with addiction, struggled with depression. She herself takes Suboxone. But the resources are so few and far between that they give them courses so that they can administer Suboxone to their fellow residents in their community. So every day people come in, and every day she talks to them, and every day she gives them that pill. And that's how they're distributed. This is another gentleman. And that's just an example. Those are the, each dose is given in one of these plastic containers. So that's just an example of, one of the garbage bins on one particular day. And the thing about that is, the thing that's heartbreaking about that is that Suboxone can, stave away the withdrawal symptoms. But to get at the heart of what caused your addiction in the first place, people need appropriate counseling. They need to, psychologists. These people have a doctor who comes in about once every 2 weeks, and it's a psychologist that comes in for about a week a month, or they have to fly out and go to a strange city and go and sort of delve into their most horrific things that have happened to them in the past that explain their addiction. So they're doing the best they can. But in terms of sustainable recovery, a lot of what they said to me was, you know what, our next move is to get off Suboxone. But that's a tough thing to do when you're not able to get at the root of what's causing your addiction in the first place. And so a lot of people ask, well, why don't they set up counselors in their own community? It's a great question. And one of them was Sid, who I showed in a previous slide. But he said to me, you know, we did set up counseling, and the thing is that people would come, very few people would come, because imagine you're in this community of 1,300 people. You're talking about the most personal, painful experiences of your life. You're going to somebody's office. He's your neighbor, possibly your family member. You walk out after that conversation, you see him down the street at the coffee shop, or you see him at a family gathering. People aren't going to respond to that. So that's one of the challenges. It's complicated. What the answers are a discussion for another night, but that's what people are dealing with. And now I just want to introduce you to, I know time is running out, but I did want to introduce you to this family. This is Tristan. He was 21 years old when he overdosed last year on cocaine. This is his mother, Kathy. My colleague, Ian Hannamansing at CBC The National, visited them, and I just want to let them tell their story. If we could hit play on that. Thanks.
22 years ago, I gave birth to Tristan, and today I buried his ashes under this tree. You know, every day people are dying, and families are being broken, and this is how birthdays are being celebrated. Right? It's like, this is my son's birthday party. This is it.
By the time Tristan was a teenager, cocaine had taken over his life. His mother, Kathy Wagner, tried desperately to help him, even taking Tristan to China when he was 16 to pursue his passion, kung fu, and to get him away from drugs. For a while, it worked. But just 10 weeks ago, Tristan relapsed. He used cocaine that was laced with fentanyl, and it killed him. The coroner's office says in more than 80% of street drug deaths in British Columbia, those drugs contain fentanyl.
Many people out there are deliberately poisoning drug supplies. And they're poisoning drug supplies because it creates more addicts, creates more market, and is easier for them to transport. And they don't care about the number of the deaths along the way.
These are some of the faces of the fentanyl crisis in BC, the boy next door or down the street. That's Tristan on the left, his friend Scott Gu and Ian Chalmers. Scott and Ian are still alive, but their parents worry for how long. I visited their mothers at a cabin on BC's Sunshine Coast near Vancouver. Their son's addictions have brought them together.
I had based my everything on how he was doing.
Luke Cameron's son Ian has struggled with cocaine and the risk of relapse. Here he is celebrating clean time at a recovery festival last year.
So that's just to give you a glimpse of another group of people that are affected by the opioid crisis. And very quickly, I just want to mention there is a class action lawsuit against Purdue Pharma that I've been covering as well. It essentially was settled, or Purdue agreed to a settlement of $20 million. $18 million of that would go to the plaintiffs. There are hundreds of plaintiffs in this suit. $2 million would be divided up among every single provincial and territorial government health authority. Part of the settlement means that the provinces and territories can never take action against Purdue again. Part of the settlement is also that Purdue does not claim responsibility for any of this. This is just a settlement that's been reached. In order for the settlement to be certified and to be approved, it has to go through it had to go through 4 provincial judges. Ontario, Quebec, and Nova Scotia judges all approved the settlement, hoping that the plaintiffs would at least get something. By the way, when we divided it out, the dissenting judge in Saskatchewan kiboshed it, it said, gave them a chance to come back and said, come back, I'm not sure if the settlement really addresses the needs, because it would work out to about $11,000 per person. So rehab, addiction, loss, everything associated with that. Purdue is appealing that because Purdue would like to see this settled. So Purdue is due back in court in Saskatchewan on July 12th, I believe it is, somewhere in early July. So we'll watch and see what happens with that. One of the plaintiffs is Stephen Mcgillvary. He was in he basically fell on top of a fire hydrant in Cape Breton, was on OxyContin for his injuries, and he said in an interview with The Current, CBC's The Current, he lost his family, he ended up stealing, he was so desperate to get Oxy. This was a guy who never thought that this would happen to him. And I just want to leave you with, this is Leon, nicknamed Pops Allward. He's standing at the Moss Park overdose prevention site in downtown Toronto. I met him. I went down there one night to talk to people about the opioid crisis and to get a firsthand perspective. So Pops is both a drug user and a volunteer, helps to keep his buddies safe. And he was actually using fentanyl that night. He went there to try and use it safely. And I asked him, I said, you know, so many people want to know why. Why are you taking this risk? Why, you know how dangerous this is. Why do you keep doing this? And he said, I would rather take the risk of dying than go through the sickness of withdrawal. He said, I know it sounds insane to anyone who's listening to me. He said, but unless you've ever been through that, you don't know. So I just want to leave you with that. And we've seen a few different people from different areas. So again, if the one thing that I've learned over the last 6 years of talking to people and covering this crisis is that this isn't any particular socio-demographic group. This is not a particular, it doesn't discriminate. It can happen to anybody. And I think the next speaker, I think that Rich will introduce, Matt, actually probably knows Pops. He was part of founding the Moss Park Safe Injection Site. So I'll leave it there. Thank you.